So welcome everybody. Thank you for coming to our breakout session. We are talking about transformative collaboration, exploring challenges, building resilience, and strengthening partnerships. My name's Kate Marr. I'm going to be the moderator today. I am the Executive Director of Community Legal Aid SoCal. We're a legal services agency serving Orange and Los Angeles counties. And I had the privilege of being part of one of the first domestic violence healthcare partnerships in a former role with Dr. Nicholas, who's one of our presenters. I'm going to give a brief introduction of each of our presenters. They have fabulous bios in the program, so you can read more about them there. And I don't want to spend a bunch of time on that because I know we definitely want to dig into the topic at hand. So we intentionally wanted different perspectives on the panel. So first off, we have Dr. Elisa Nicholas, who's joining us virtually. She is the Chief Executive Officer, and she's a pediatrician by training at TCC Family Health. TCC is an innovative and inclusive federally qualified health center system with 13 sites and a mobile medical clinic serving over 40,000 patients of all ages in 140,000 visits per year. So she's representing the medical perspective today. And oh, that echo. Okay, that's okay. And to my left is Debra Ward. Debra is the Chief Executive Officer of the YWCA of the San Gabriel Valley. And I have notes here that I meant to, I have them in order. What did I do with them? I'm sorry. Debra is representing the provider perspective today. And the YWCA of the San Gabriel Valley focuses on serving the most vulnerable, including older adults, survivors of domestic violence, children and youth impacted by trauma and violence, and building resilient, equitable, and healthy communities in the San Gabriel Valley. And then for the public health perspective and the sort of government county perspective, we have with us Eidem. Ellen serves as the director of the Los Angeles County Department of Public Health's Office of Women's Health, and the OWH works at the community and systems level to improve health equity, decrease health disparities, and improve the health status of women throughout LA County. So thank you to all three of you for being here, and thank you to our fabulous audience, both in person and in the virtual world. So we're going to get started. As I said, we're bringing perspectives of folks who have participated in domestic violence and healthcare partnerships, and then an outside partner of ours from the county. So I'm going to ask each panelist to please start by describing your partnership model. Who were the partners? How were referrals handled? How was the partnership funded, and whether or not your partnership is still operating? And I will start with Dr. Nicholas. Oh, you're muted.
Sorry. Good afternoon, everyone. Thank you for allowing me to call in and be seen by video. Sorry, I'm not there in person. So we've had many partnerships through the years, but the partnership that really started the focus on our domestic violence work was through the Blue Shield grant that was from, I think, 2014 through 2016, around those years. And our partners were the Medical Legal Partnership, which Kate helped us start when she was at LAFLA. And we met through the Building Healthy Communities work we were doing. And we had two domestic violence IPV treatment partners in Long Beach. One of them had a change in leadership, and it was challenging to engage them. So eventually we were working with one with whom we had a really good relationship, and that went well. And then, of course, Futures Without Violence was leading on a big part of that initiative. So I met them through that. I think the partnership as it was then is not really the same now. But what has happened was that we've been able to leverage those relationships into other really exciting work that we've been doing. For example, we now have selective home visiting, where we go in and work with at-risk families up to the age of 3, which is very important. And domestic violence and ACEs in general is very woven into that. We also have continued our medical legal partnership. We've partnered and written grants with Futures Without Violence, that relationship from this. And through that, we have funding from Innovation 2 through DMH. And that's doing a lot of work. And actually, during the COVID pandemic, we brought in Futures Without Violence to educate our whole collaborative, which is about 20 different organizations, quite varied within Long Beach, about not being really safer at home. So that's continued. And we also became the first trauma-informed care certified organization in Southern California. So that may be too much. Hope that's okay.
That's perfect. Thank you. And just so the audience knows, both in the room and virtually, we are going to have an opportunity at the end for questions. So write them down if you come up with one, put them in the chat, and we will be getting help addressing the audience questions at the end. Okay, Debra.
Okay, good afternoon, everyone. Debra, YWCA, San Gabriel Valley, and I'm going to talk about 2 different partnerships because when I started with the DV Healthcare Partnership, it was with Genesee Center, and I was involved in writing the grant, getting the grant, and administering the grant, and developing the MOU for the partnerships. That partnership was with Watts Healthcare Corporation, which was located in the city of Watts, and with our larger domestic violence and prevention programs. Genesee had always had a health component built into their delivery of services. They had a part-time nurse that they invested in paying for. It's not one that's usually on a grant to support, but due to their commitment to wanting to ensure that women who were impacted by violence, or anyone impacted by violence that found themselves in the shelter, that they would have access to a health assessment. Through that partnership, just in terms of some of the questions, we were able to develop the assessment form, redo the assessment form. I see my former colleagues like, okay, I'm gonna look at them and like, right? No, Genesee table is over here. But we were able to redesign the form so that we could ask health screening questions, so that if there was an opportunity to assess like a client, if they needed birth control, if they needed a physical, if they had some type of chronic or long-term illness, we were able to identify those kinds of issues, and had a referral set up with Watts Healthcare System in order to have a warm handoff that would be sent, that would go to Watts Healthcare. It worked out excellent through the 3 years that we were funded. It is after the pandemic, we just ran into, I believe they just ran into some issues, and we have to re-engage the health institution again. Many of you probably have experienced the staff turnover that has happened across the board. So people have moved, and your existing champions aren't there. So therefore it slowed down the process, but they still do have numbers and people to reach out to at Watts Healthcare Corporation. So I think it's a matter of us re-engaging that process. And then if I can just speak briefly, I wasn't with the YWCA when they had the program, but some of my colleagues are in this room as well. But they had a different experience. They originally went with 2 FQHCs, one federally qualified health center, which was in the Pasadena area, and it didn't work out. So before the 3 years was up, it just the MOU, just the contracting didn't really happen. Matter of fact, in that 3 year of funding, they transitioned to another provider. So not all the partnerships went as indicated in the proposal. They later provided a MOU and an agreement with East Valley Health Center, another federally qualified health center. And it was from that relationship they were able to develop the referral systems that were required for services. So that's my beginning.
Okay. And Ellen, so Ellen, you were not part of one of these sort of individual partnerships, but you have kind of the county's perspective after the Blue Shield grant and talking about how you got involved in this work and with the Leadership Council.
So what I'm going to do, hi everybody, I'm Ellen Eidem, Director of the Office of Women's Health, a part of the Department of Public Health. So actually I'm going to start a little bit back a few years before that, which was that, you know, while all these partnerships were flourishing, we at the Department of Public Health weren't involved in it at all. But personally and professionally, I always felt like we should be much more involved in the work of domestic violence, intimate partner violence than we were. And I know many things started happening. One was that we started working with many of the colleagues here or your organizations at the board of supervisors level, looking at the intersection between homelessness and domestic violence. That was kind of a big kind of lifting up and elevating of the whole issue kind of on a county level. We started in the Department of Public Health, we started a gender-based violence work group that took in kind of all of the different programs on the clinical side and on the administrative side, and programmatically saying, like, how do we look at the issue of domestic violence within public health? And we started working at, like, what should be our role? What we ended up doing was we spoke to many of you in the provider community and said, what do you think as public health? What should we be doing? How do we not step on anybody's toes? How do we not duplicate the services that are already out there? How do we bring the public health lens to kind of looking at something at a population-based level, looking upstream? How do we do some of this that will add to value as opposed to do some of the things that you all were doing in an expert way? And so many of you said, number one, look in your own house, like look in public health. How can you be helpful kind of within public health? And the other part that people said was, think about the provider community. Think about the folks that are providing services but are too afraid to even ask, like, you know, their issue related to healthy relationships or to domestic violence, because they don't know what to do when they get an answer. And so that was the recommendation of kind of what we should be doing in terms of public health, which is what we began. And we began an internal whole big campaign to try to train our own public health nurses, to train, looking and one was public health nurses. One was we started a program called A Deeper Dive. And that was many of you became our teachers and trainers. We worked with the community to help train, I think it was about 40-ish kind of champions within public health that could go back to their place of work, whether it was in the community or whether it was in kind of a programmatic arena, and be able to be that champion related to domestic violence. And trying to look at some of those different intersections. So that was happening. We also started a program called the Clinic Champion Program. And that was to really work with our clinical staff to say, building the champions And then the key part, which I think was mentioned both here and other places earlier today, was that the resources, the connection, helping people make the connection between wherever they're working, say in a public health clinic, with the resources that are in the community, and trying to enhance those referrals and resources. So part of what the other thing that was on the agenda was that we were going to be helping to train our Department of Health Services folks that do the clinical work with women's health. But COVID actually got in the way there. And so we never actually were able to follow through with that. So jump ahead to 2018, like this is all happening. And in 2018, there was some massive changes, which is that one was that the Domestic Violence Council, which I think all of you know and know about, it's kind of that touch point for anybody within Los Angeles County that touches domestic violence in any way, shape, or form, has a space to be able to come to and learn. And the Domestic Violence Council was moved over from what was called the executive office within the county system over into the Department of Public Health. And so they sit now within the Department of Public Health, trying to give it kind of the bigger picture, the upstream picture. So DV was then DVC, we call it, was then moved over to public health. The other thing that dramatically changed was that the DV shelters and what we call the DVSS, domestic violence supportive services contracts, they were moved over to the Department of Public Health under the Office of Women's Health. And those were those that Supervisor Kuehl spoke about this morning. So those are the 24/7 shelters that provide all the services. Those are the services that are the counseling, the education, the legal services, all of that the providers provide. So those contracts came over to the Department of Public Health. And then the other part was that the Office of Violence Prevention came into the Office of Women's Health. So they really are trying to look at, what are the root causes of violence? What are the multiple forms of violence, and how we all kind of work at the community level, at the societal level, et cetera, to make a difference and to make those changes. So all of that was happening, and we also began collaborating with the Leadership Council. So, this has been, and so what we ended up doing was we ended up working with our colleagues as the Public Health Department to, work on kind of the first Breaking Silos conference, the second, and now today is the third one. So we've been working together for now probably 4 years-ish together as a Leadership Council, and we have learned a tremendous amount as a government entity from our colleagues from the community.
Thank you. Okay, so I'm gonna just throw out the rest of these questions and y'all can just jump in. Oh, Debra, you want to add something?
If I just add a little bit?
Oh, sure, of course.
Just a little background on the DV Healthcare Partnership Leadership Council. So the funding we received from 2014 to 2017 ended in 2017. And many of us in Los Angeles experienced some great outcomes. And many of the CEOs that came from East LA Women's Center, Kate's organization from the Legal Southern California Agency. She changed her name, so I keep mixing it up. But from Kate's organization and Genesee and the YWCA. And we felt it was important to continue the work. And so we went back to the funder and said, we had so many great outcomes. Would you mind funding us for an additional 2 years to see if we can spread the word and spread the outcomes? And I think when it came at the same time, 2018, in terms of the movement to the Department of Public Health,
Debra's frozen on my screen. I don't know if you can hear that.
Are you getting anything from the virtual audience that it's frozen?
She's back on now, Kate.
Okay.
But she's kind of fuzzy.
Okay.
And
All
going
right.
in and out. And going in and out. Sorry.
Okay, well, I'm getting ready to close on this subject matter. I think my point was that, and I think, this session is about models and how you think out of, and we were funded for something. It could have just ended and we could have just left it, and we didn't. And at the same time, the Department of Public Health was making some strategic moves and changes, and it happened that now the providers within DV are now within public health. Domestic violence, intimate partner violence, sexual assault is a public health issue. So from many of us, that was a win and advantageous to the movement. Do we still have work to do? Of course we do, but we felt like some missions were starting to be in alignment. So I just kind of want to bring that to you all, and that's why we're here today. And those 4 groups, that's why you see the 4 agency logos on the first page with the cover letter. It really is those initial groups that were funded, and we didn't want to say no. We wanted to say yes, and if we got to do it ourselves, we were going to do whatever we could. And thankful to Blue Shield for funding our vision.
And the one thing that I would say, I think that's really sort of unique about that funding and the way that it's continued is that it's really not focused on like the individual agencies and direct service, but more big picture thinking of how we can make changes with some of the lessons that we learned from those individual projects, make them big picture thinking, big changes countywide at the intersections of DV and healthcare. But so back to partnerships, obviously we all know with the good comes the bad sometimes. So I'm just going to throw it out there for the panelists. If you could talk about maybe some significant challenges that you faced in your partnerships and how you and the partners work together to overcome them, or maybe not overcome them. I mean, everybody did, I think, in their initial introduction mention at least some challenges. So anybody want to jump in there?
Well, I'm happy to start with that. I know that people had mentioned power balances. I don't really see it more as power. I mean, I don't think any one group is more powerful than another. I think we all have very different cultures, and the way we communicate, the way we bill, the way we are supposed to interact with patients is a little bit different. So I'm looking at legal, behavioral health, which was really, we grew it tremendously through the last 5 to 6 years, and since we had this grant, and then the IPVD providers and the shelters. So I think just learning to speak the same language is really important. And when we first started working with some of the homeless mental health providers in some of the Mental Health Services Act funding, it was very hard for us because it's a very different way of approaching how you do business. So I think that's really understanding each other's cultures. I think we have different training. I think behavioral health is more comfortable, asking those hard questions. Internal medicine is probably one of the least for adults. Pediatrics, we're used to asking how things are going. And in our organization, we had already gone through the trauma-informed care certification and training. So that really, really helped. But I think the other is the time for the training and those challenges, both for our DV partners. I went into I was blindfolded. I was taken into the shelter with my partner, which was really enlightening for me, because I offered to train them in how do you recognize if a child is sick that's staying there with their mom. And, so we just had question and answer. I was very open. I had handouts for them and talked a little bit of adverse childhood experiences. And then they came and trained our staff. And that training is something that always has to be ongoing. Then I think the biggest challenge we faced was the fact that, and Debra mentioned this, the staff changes. Both the staff on our side and the staff on the domestic violence side, providers, that it's been almost completely, it's all different than when we had our grant. And how do you maintain those relationships? And then with COVID, that was just, we were all so busy. And I think a lot of that, being introduced to each others would have happened in Long Beach at the End Abuse Long Beach meetings, because I know Kate's very familiar with those, that where everybody would be in the room together and you would have time to meet each other and introduce yourself to each other. So I think that was a very big challenge. And then the IT systems and the configurations and the legal aspects of what we can share and how. And through our medical legal partnership, we know that certain things can't be written in their charts and certain things can't be written in our charts. And how do we manage our, co-manage our families together? And then, now one of our biggest challenges is there's just not capacity for our families that need to get into a safe environment. So.
Okay, so turning it over, we got all of your answer, Dr. Nicholas. Thank you. So I'm going to turn it over to Debra.
Yes, and I was just saying that I'm going to focus primarily on the Genesee and Watts Healthcare Corporation partnership. And I guess before talking about the challenges, I just want to mention the maybe the strengths of the partnership because it informs the challenges. One is that building trust between the partnerships. When you have models and you're going from a DV model to a FQHC, a different type of model, and although you service the same marginalized communities and vulnerable communities, the organizational culture is a lot different. And when you come to the question about the imbalance of power, I don't know if it's a imbalance as much as it understanding the power, that all organizations have power. So whether you're DV or FQHC, a hospital, or whatever, you're working with a hospital, your power dynamics. So being aware of what those power dynamics are, and then doing an assessment of how that power dynamics is reflected in your decision making from our standpoint, from Watts, the FQHC, they're a one-stop shop. They're big. They're like, $60 million company. We're under $5 million company. You got to be able to understand those dynamics. Their priorities are not your priorities. And understanding that allows you to move forward with building trust. You got to have trust between your partners. That's where you can put the MOU and everyone can conceptually be on the same page. But when those power dynamics occur internally for different organizations, they manifest differently, and it impacts how your partnership moves forward. So I think we experienced some of that. I think in terms of the organization culture, that's why we did training. Dr. Nicholas mentioned how important it was to do the cross training. It was just equally as important for the medical providers, nursing staff, case managers, because they hired some of the same individuals that are in the DV provider world, but their lens is a little different. And for them to participate in the 40-hour training and have special training for just the medical community that resides in their agency was a tremendous help. And it was then, it kind of takes me to the, I'm going down your questions, but how did the medical providers welcome it? Because we had the champions, and champions have to occur at the top. If we didn't have a vice president who had an ear to the CEO, and the CEO understand the importance of the partnership, I think that's when partnerships kind of lose their synergy. And so we had that. The challenge was for their organizational culture and the complexity of their organizations and priorities didn't always prioritize the DV client, and to be realistic, and that was and I think that was the challenge, and we had to name that. And I think it goes back to knowing the power structure within different agencies. Once having the trust, we were able to sit at the table and talk through some of the challenges that our clients were having. Even through the training, being able to, somebody said holding your arms like this and going into a training. We saw that resistance with some of the medical providers during our training, because they felt like they had a one-on-one session on domestic violence, and their doctors, our PAs, our nursing practitioners, and they didn't have to have the training. And you saw those who were a little bit more trauma informed and understood that the intersectionality. You saw those doctors stand and voice their issues, but some of the others were very resistant. And lastly, I just want to say, in terms of that resistance, because in our community, at least in South Los Angeles, we have medical providers that come from all over the world. We have very diverse, and they come from different cultural customs. And that, as much as we don't want it to reflect in how we deliver services to clients, we found that to be issues too. Whereas that's where some of the resistance was, like, well, I'm not going to ever ask this question. It's too private. I'm just not going to do it. And so we really had to work through some of the behavioral practices from their cultural upbringing. So those are some of the challenges.
Hey, could I comment on some of what Debra said? Because I think,
and then I'll go to Ellen.
Is that okay?
Yeah.
Okay. I mean, I think Debra really articulated well. I think one thing is you can't plant seeds on soil that's not tilled and fertile. And I think, you have to get people to a place where they realize how important this is before you can just develop a relationship. And it takes a long time to develop respect and trust. And I think some collaboratives that don't work well are ones that we just try to push ourselves on rather than have them grow up organically. And I think what we found is, because of some changes in leadership, the one group we thought we were going to work with, because we had a connection through one of our doctors on the board, really, they were a new organization from what we had first met with, and they weren't ready to try to do this together. And then the other one turned out to be wonderful. And I think that was really important. And the more you can build those relationships and trust, then they can understand each other better. I think it's really important, and building the capacity on both ends. I hear what Debra is saying. We have a very diverse workforce also. We have to try. I asked some of my doctors recently, how much domestic violence are you seeing? Through the work we've done, those questions are embedded into our EHR now, through the advocacy and the work I did with 4 CAs, and we now have the ACEs and the PEARLs that gets reimbursed. I was working for many years trying to advocate for that, to have that in our screening tools, and through the CPSB. We have the questions there. But there's ways to ask those questions. And I think you can train people how to do that, but they have to be open to hearing how to do that. And so I think really trying to work through that is important. And then the other is competing priorities. I mean, everything kind of fell apart in healthcare that were those extra things that we were doing that was so important. during COVID, because we were just trying to keep our staff well, keep our patients from not dying, and making sure. But, you know, as I said before, safer at home was a huge red flag for the women and men that were in violent relationships. They were locked together in the house. So we made a really a conscious effort to train our staff and talk about those issues, and brought in Futures Without Violence to do some training of our current Innovation 2 funding we have. And so that was a really important piece to that. And I think for us, I tell people, if you don't want to learn something new or learn new ways to work with your patients and families, don't come to our organization, because we pride ourselves in really looking and doing things in a different way. And I think the other is, if you're uncomfortable asking the hard questions in a way that is appropriate, this is not the place for you, because we do ask about adversity. We do ask about trauma. And one of the speakers earlier, I think, was alluding to that on one of the panels today, that, you know, firemen still have to go into fires, even though they've been traumatized by going into a fire before. But for some people, and through my experience, you know, since we've been doing this more intensive work in this field, is that for some people, going there is they're not ready to do that. And this is not the place for them to be working. Because we are going to ask those questions, and our medical assistants and our doctors and everyone in the organization is going to be having to talk about this, and talk about domestic violence, talk about their past history of abuse. And for some people, that's really hard. So how do we make sure that staff that are joining us are comfortable with that, and how can we help them do that better? So.
Thank you. I think that's a really important point, and especially in this job market where it is so hard to keep employees, it's hard to say, if you're not comfortable with the way that we're doing things, then this probably isn't the place for you to be working. But I think when we do this kind of work, we have to have that conversation with people. So Ellen, do you want to talk about some challenges?
So, as you know, the Department of Public Health is county government, and everybody knows sort of when you think of government, you don't think of nimbleness, you don't think of flexibility, you don't think of kind of being able to move quickly in any way, shape, or form. So in terms of kind of looking at kind of what are the multiple kind of hats that we wear in terms of the partner relationships, you know, we're the first to say it's tricky. It's tricky because we want to be partners with people. We want to be collaborators with people, but we're also contract administrators. We're also we have the responsibility to oversee kind of contract management on things. We want to be, we work in multiple tables in terms of collaborations all over the county. We work as data collectors in a variety of different ways. Dream in so many different ways, and yet the funding sources for everybody, the intervention side. So it's, it's like we can talk a good game, and I don't mean that disrespectful to anyone else, about prevention, but where are the dollars for you all to do what you do? You know, it's not there, and we haven't had the dollars to be able to provide that either. There is, a cultural difference in that way. And no matter how much our intentions, and I believe, that 99% of those people have good intentions, it's, the reality is there is a strong mistrust of government out there. And that is true. And so part of what, what we're always trying to look at, what is a system-wide effect? What does it mean to change systems? And sometimes you have to look at, especially because the way the county, because of the bureaucracy, quote unquote, related to the county. So most things are never simple to fix, most things. And sometimes they are, but it's like, what category do they fall in? Do they fall in kind of legislative fixes, like things like changing the law and reporting DV, like who has to report and, what do they report? That's kind of a big giant fix, but that's legislative. There's things like, I'm going to talk a little bit more about sort of the safe haven for abortion services. there is a major legislative fix because we live in California where money is flowing in related to kind of abortion services. And there's things like that the county, the city, the feds, the, LASA, HUD, all of those folks, interdepartmental kinds of work that need to get addressed. And that's, the deviant housing and homelessness, issues, the American Rescue Plan. All these are like complicated, big issues and then there's some things that it's like, okay, there needs to be training, there needs to be elevating the issue. We need to be at the right tables at different times. So, I mean, there's different kind of categories of things. And sometimes you need to just listen to the community. We need to listen to what people are saying, listen to what people's needs are. The woman that spoke earlier that said, have a different emergency room. It's like there's certain things that just hit you like, like, okay, that's, there's certain things that what it means to actually hear. And, it's become a kind of a buzzword in terms of community engagement. But what does that genuinely mean? How do we genuinely make that part of the voice of kind of, and all of these things that I mentioned, they all need resources. The last thing, is that and the people end up being competitive over very limited resources. And that, is obviously the last thing anybody wants, but is a reality out there. I want to use an example because I would be remiss, especially since my boss, Dr. Debbie Allen, is here also, I would be remiss if I didn't say the biggest challenge for public health in the last 3 years has been COVID, and COVID kind of not only the pandemic itself, but the management on every level of it. But I want to just say something about a lesson that, has been very instructive to many of us in public health, which is that what does it mean to be able to go to, like, okay, we had these giant pods that were areas where people could go get vaccinated. They were gigantic. People would come in by cars. They would have, they were busy. They were on and on and on. But then it's like, well, who wasn't getting vaccinated? Which communities that are the most in need weren't getting vaccinated? And why was that? And what does it mean to go back to really go into the communities where the needs are there, and to be able to meet the needs of what the community, the trusted leaders are saying, all those folks that really can make a difference in their own community, whether it's the faith leaders or whether it's community leaders or whether it's, the person that's somebody's grandmother that can be able to bring people together in a home. And I think that the lessons related to that for public health have been massive. And I think that it causes all of us kind of pause to think about, and a humility that says, what does it mean to really think about what the community's needs are? What does it mean to think about kind of true disparity, true equity? And I'll stop there.
I just want to lift up what you just said, because I think service providers so often have gone into community thinking that they know best instead of actually really listening to the community. And if nothing else comes out of COVID, like hearing that message, that maybe the community knows best what they need will be a huge benefit. I know Dr. Nicholas, I was not being rude. She was texting me that she has something else she wants to say. And I will, one thing that I just want to add, and moderator's privilege, I'm going to add one challenge that I think people touched on, but also knowing up front, like sort of the legal requirements that each partner has. Like someone mentioned, like conflicts related to mandated reporting. Like I, as a legal provider, am not a mandated reporter, and I absolutely cannot report no matter what. And having that different requirement than my partner, and understanding that up front, and how are we going to, and when those conflicts inevitably arise, how are we going to handle it? Like identifying some of those issues up front, using those conflicts when they do arise to actually talk through difficult issues and come up with solutions that work for both partners is key. And I know Dr. Nicholas had a comment about shelters and shelter beds?
Yeah, I think it's kind of bi-directional. I mean, we have a shortage, a manpower shortage in healthcare right now. There's a great resignation. People don't want to come into the office. The physicians are exhausted. We're short-staffed. Every community health center that I know of is short-staffed, both nursing, physicians, everything. So, but also when we have a family that needs to get into a shelter, the shelters are all full. So, both sides of what needs to be done, because we were getting referrals, we get referrals from the shelters. That was part of our, partnership, was explaining to each other, what can we do? Just like with our medical legal partnership, LAFLA sees many patients that need health care. They're our medical legal partnership. We're here to serve the community. We've been here for over 80 years. So we're here, but sometimes we don't always have open slots because we have doctors that are not working anymore. We've had a bunch of retirements recently. And but we also have patients that need to get into shelters. And recently, when we tried to get them in, there was no space. So I was texting Kate, who funds the shelter beds? Is that county funding? Is that federal? And is that something we can advocate for? So, there's many different, not everybody who has domestic violence needs to get into a shelter. They're, and as talking to our behavioral health, we have been able to expand our behavioral health to better serve our patients and those referred into us. So that is good. But we have had more problem getting people into shelters. And I just would like some insight, probably from Ellen, about that, if the county is funding that.
Great. So I'm assuming you two can follow up with each other about funding for shelter beds. I often bother Ellen with my questions about funding. So, I think obviously along with challenges often comes strengthening, right, of partnerships and building resiliency. So do any of you want to speak to, or could you speak to, how facing challenges and working through them, maybe some examples of how those help to develop resiliency and actually strengthen the partnership, or lead to better services for patients or clients?
Do you want to go first, Debra, or you want me to go?
You can go.
I think seeing how much we have in common rather than being the giant clinic. I think what's hard for me is when I came to the clinic, we had 7 exam rooms, and I'm still here. And, I don't think there are many CEOs that will go and give a lecture in the DV center, but I've been doing that for years, not just with the one that we worked with most recently, but others that have been in town. But I think really how building trust and understanding, and how it's mutually beneficial to both of us, not just us using the shelter so that we don't have to think about the family anymore, and the doctor can, because I think that's one of the scariest things for physicians is, if you ask a question and you can't do anything about it, then they feel powerless. And a very famous I'm a community pediatrician at heart. I have a degree in public health also. So that's kind of my lens. And the father of community pediatrics said, it's very hard to ask a question and to delineate something that you can't help. And he was kind of the father of social determinants of health and all those issues. And if you can't find them housing and you're asking, from a research standpoint, you may have added to the knowledge, but from an individual response to a patient in acute need, and that's what physicians are used to doing. You see a problem, you treat it with a medication, you look in their ear, that's what we do. We're trained to fix things. And when they can't fix things or get them into care, it's very frustrating for them. So I think the more we can, if we say to the shelter that we'll take care of your health problems and they can't get them in, they get frustrated. So I think that's something to understand, and really try to build that scaffolding around to help them not go through that. So, and then realize our shared values and goals, and really calling that out.
Yeah. Okay, Debra, Ellen?
I guess I would mention maybe 2 situations in terms of, pushing through our resiliency. One would be going back to Genesee. We were doing the referrals, and we were finding that we had a satellite clinic that we sent a lot of our clients to. So there were two different clinics, but one that was closest to us, we would send clients there, and we had mixed reactions. So you have the big center and administrative offices with all the champions of this in Watts, but this little satellite clinic that was closer location wise to us, they didn't go to the in-services or the trainings. And so when we would take clients there, the referral system just really didn't work. And pretty much we found that our staff would come back and say, well, they took us, but we're supposed to have immediate access, and then we're supposed to take them in a special room. So they just didn't connect at that satellite. And so what we ended up doing was talking with the administrators and creating a card with a color on it. Because the other thing that they were saying when the client and the staff presented themselves, they were like, who's Genesee? So, confidentiality. So that's the clerk. That's not the doctor. So, you have different people who go to the training, but you got a complement of a team that didn't know the process. Mm-hmm. And so we learned that we got to go multi-layer. Mm-hmm. You got to go deeper. So again, you have to begin to look at the different aspects of the referral system. And then at the larger clinic, going back to the physicians and the providers, they didn't have it coded in their electronic POM. I don't know. You mentioned it earlier.
The EHR?
Yes. Electronic health record.
Health record.
Yeah, they didn't have it on their little Palm device.
They work on these little Palm things. Okay.
Yeah, and
we have bigger screens.
so we had to make sure that we went through IT to change the data fields.
Yes.
To program their little devices. And so that wasn't until later. So there's so many pieces that have to be looked at. And I think, again, going back to trust and being able to have those discussions and being able to pinpoint where some of the issues are and having the partnership that allows you, can we change that? I think they looked at us a little crazy, like, do what? I think that it was the IT department. They were like, do what? Like, well, that would require such and such. It's coming from the top. It got done.
Yeah. For us, we are fully integrated with the hospital, Debra. So if you want to see a challenge, if we want to change a field in Epic, which is what we have to work with the whole Memorial Health System to try to get that change. And I think IT is never spoken about, but it is often the hardest challenge we have. And then, the safety issue, just, changing the policy. If someone comes in and asks if a patient or an employee is there, just to train all your staff to say, we don't know. And then you go back and you ask the patient or you ask the staff, can they come in? Because I'm sure that most community health centers have had either a disgruntled or an abusive spouse or partner of a patient or a staff try to come in to the clinic and see them. So, and that can be a life and death. And we've had some of those things happen. So, and once you make that policy, you're going to get new staff, and many will not know it anymore. So that constant retraining of your staff, it's human nature to stop doing things once you set up policies. And so I think we all forget that, and it's something we have to be reminded of.
Ellen, do you have?
Yeah, I'm going to give a couple examples, one which is a kind of DV related, one that's not. But first of all, the issue about breaking down silos, like what that means in general and what it means, like in Department of Public Health, as you can imagine, we are very large. We're a very large system, and we have a very intentional effort to try not to live in silos, and yet it is so difficult, even among ourselves in our own bureau under Dr. Allen. You know, it's like Office of Violence Prevention, the Domestic Violence Council, Office of Women's Health. We, you know, often the different programs are funded singularly, and therefore, even though with incredibly good intention. So I state that because I think it's the obvious, and it's also what gets in our way at different times to make sure that we are all on the same page, going in the same direction. You know, so a couple of examples. One, which is the non-DV example, is that I wanted to talk a little bit about what was referred to this morning as the Safe Haven project related to abortion services, sexual and reproductive health, including abortion. This is one where the community came together, the advocates came together, the organizations that were working in the arena of sexual and reproductive health and abortion came together, both at the state level and locally. And this has made a dramatic difference. Now, meaning that, you know, yesterday Governor Newsom signed $200 million that are coming into California to be able to meet the needs of those that are most marginalized within California and those that are becoming from out of state. And this was one of those this is a partnership that is still in bloom. I mean, this is people are still, there's going to be the people, the community organizations that'll get some of those dollars that are going to be able to serve a very unique population, whether it's the LGBT community, whether it's the Spanish speaking, the Korean speaking. There's going to be all kinds of dollars that are going to come into Los Angeles in particular and throughout the state to be able to meet those needs of the marginalized and those that are coming from out of state. And it's everything that was just talked about, because you have to think of security and the IT part of it, and and what's the developing the workforce and all the training parts and the navigation. Each of these things need attention, but it's because of the collaboration, because of the partnerships. This is going to be tricky. I'm not saying we're at the end of it. We're at the beginning of this, but it's because these commitments that partners have had to be able to make this happen. And so that's an incredibly positive example in so many ways. The other is a much smaller local to home example, which is that that's a part of the Department of Public Health. It's within our Office of Women's Health, and we have about we started looking what's the partner violence and being an older adult, and what are the systems that
it's the noise in the back.
Okay, sorry. So what are the systems that are out there that that are so siloed? Because the aging network deals with the older adult that might be experiencing elder abuse and intimate partner violence, for example. And then there's the DV network that's looking only at the DV part that really does not do well. It doesn't have there's no resources, and there's minimal expertise related to dealing with the older adult population. So out of that, we brought together both the older adult population, the aging networks, and the DV networks. And now we have a learning collaborative that looks at, we call it Late Life Intimate Partner Violence Learning Collaborative. And so part of this, we've just had two kind of big convenings looking at the issues. We have a third one coming up in October that I think it's the 27th. And we are looking at what are the services that are out there, what are the gaps, and how do we actually, change things so that there's no wrong door for an older adult that has an issue, and that they have to, that they're not told this is the wrong place for you. So both of those are different kinds of, massive collaboratives and kind of a very local one, but they're examples of things that are kind of in progress right now.
Thank you. So we have some time for audience questions, if anybody has them, and then we'll do one quick takeaway from the panelists at the end. Anybody have questions? No questions.
I have a quick question for Ellen, who I can only see your wrist, Ellen, but that's fine. How does, I don't think, I would like a response to, are we going to get more DV beds? But the other question I have for Pasadena and Long Beach, are you covering the Pasadena and Long Beach shelters that serve those areas? Since, you're the county, but they're also the separate health departments.
So the good news, which is never enough, I will say that straight away, is that that the ARP dollars, the American Rescue Plan dollars, is just being rolled out into the community like momentarily, and that will be able to, additional. It's not shelters exactly, because the shelters that we fund are the shelters we fund. There's 18 shelters, there's 29 sites. But the shelters that currently exist that get funding are going to be able to use those dollars to expand the resources that are out there. So additional beds will, be available, i.e. at, for a longer term stays, never long enough. It's, relative in the scope of things, it's still relatively short term. But so the ARP dollars will be available. There's also, if you heard Supervisor Kuehl earlier today, if you heard that part of that, she alluded to the fact that there's definitely something in motion right now that will potentially bring more dollars into the shelter-based system. That is kind of the needed additional dollars, and it's still a work in progress. So I don't have more to say on that right now, but there's there's the acknowledgement that the need is absolutely there.
Okay, and you're funding the shelters in Pasadena and Long Beach through the county?
Yes.
Okay.
Yes.
Yeah, okay, great. And how are you working with the DHS and DMH?
People in the audience have questions too.
Oh, okay, yes, I'm just looking at my little thing. We have no
I
questions.
know you can't see, but there's lots of hands raised.
Okay, sorry, never mind.
No,
Sorry.
and then we'll come back to you.
Okay, I just don't see any questions on my video screen. Sorry.
My question would be, with the additional funding, will that allow for readjustments in the amount that these services? Okay, so if you're bringing in new money, can you change whatever the amounts are, the fees are for the services that are being provided?
This is such a good question. This is
Right.
such a good question. And
I think there was
Frank-
a letter recently about
yeah,
this.
and frankly, it is something that is definitely on our collective minds. So we will pick your brain on that further. But thank you for the question.
I saw one in the back and then here and here. Did someone in the back have a hand up? No? Okay. I'm scratching.
But it was when she was mentioning that they had a collaborative with did you say layer aging or the aging and the DB, and if you guys do you guys have any information on how that can be structured?
To be honest, it's relatively loose, as in I will find you, and if you're interested, you are part of it. This is something that we want additional involvement. We have, the county's structure of Department of Aging and that whole network. We have CBOs that are part of it. And we have, from the DV side, we have some of the agencies that have actually taken an interest in wanting to meet the needs of seniors, older adults, and we have Department of Public Health. We're looking for additional partners. We've gotten a very interesting response. I mean, 100 to 150 people have come to these convenings because people are interested, but actually changing the system is tricky. It is tricky. And because people, as you get older, there's also medical needs that come with. It's not just, meeting people's psychosocial needs. There's medical needs. And so it's a complex system, but we would love your involvement. And anybody else's that this is of interest to.
Okay, here, I have two questions that for you to consider in the future. I would love to see for other organizations to get together. And all CEOs, like you were saying, and be able to unite and not have so much competition between each agency, because there is.
Amen.
Earlier, there was one speaker that said, we have to be honest. And we're not. And in this field, we're here together to do one thing. Because if we reunite as a whole, we can make so many changes. But there's so much competition between each agency, and we should, because at the end of the day, all of us are here to do one thing.
And I agree.
Yeah.
Totally.
And if I, as an agency, help you, because I need help and support, because I don't have it at the moment, it's an emergency, I think that other agencies should be open to receive that victim, to house that victim, because my agency is at capacity to house this victim that's in need of shelter. And talking about shelters and funding and money, I honestly believe that working in this field, and I have so much to learn because I'm still learning every day. I wish every agency had funds and was giving enough funds to have their own shelter, not just to house 1 or 2 or 3 victims with family, but to house 20, 50 DV. But I actually would want to have their own looking around and spending 2-3 hours on the phone and trying to send my victim all the way to Palmdale and Lancaster and San Bernardino, or out 50, 60 miles. Why me? And send them somewhere else where they're already afraid to even just come into their agencies.
If I can of today, the inadequacy of the fund promotes that inner competition. Rather, you want to see it and name it. So thank you for just bringing that out. And I do think that what you see here, the Department of Public Health, County Public Health Government, you see a DV provider. Kate has one of the largest legal agencies in Southern California. We're talking about doing a partnership. These things would not be happening had we not had a DV healthcare partnership. So change is slow. I just kind of want to mention, like with DV moving to the Department of Public Health. I think they're now going on maybe 3 years total. But I remember when those first agreements came through, they just said, we just need you to sign it while we figure out what we're going to do. And I think we have to allow ourselves grace to every sector that is working this, because we do all have good intentions, but change is slow. The systemic problems that we have in our society did not happen overnight, and they will not be fixed overnight. And I think the fact that the DV Council, which has representation from all the DV providers, is a place to start in terms of maybe addressing some of the resources and acting collectively. But as Ellen mentioned, we're at the beginning. Even when we finish, we told Blue Shield, we just scratched the surface. We have so much more to do. And the funding's not there to do what our vision wants us to do. But we have to start with where we are and try to build. And so I'm proud because we're a founding organization of this effort. But to be able to have our third conference after, I'm not going to say after COVID, but whatever COVID transforms to be, we're pushing through. And the purpose of this conference was really to be able to have dialogue, some serious dialogues with providers in the field. Healthcare, I'd like to see more healthcare participation. So we still have some work to do. Our keynote speaker mentioned about bringing more power into the room. We'll think about that, in terms of doing that. That was, and we have, but again, it's the readiness of those different sectors and the education that's needed.
And I know we had one more. I wasn't someone on. Okay.
Sorry.
Okay, I have one question. During the pandemic, I did work at a shelter, COVID shelter, and we had several domestic violence cases there. And one of my frustrations was, because this was kind of new to me, I'm from DMH, is that when I called, it's true there was no bed availability, but was really surprising to me is that each one that I called had their own criteria. So that really blew my mind. Can you talk about that? Because I would call and say, well, is it one? Well, I had one lady with 2 kids and COVID. Oh, we don't do out of state. And so, I was on the phone for like 2 days, and every place that they had all their own criteria, and these women were in crisis, and one was a gentleman seeing his partner. I didn't know that you had to have certain criteria. So we thought the criteria was just the domestic violence.
Mm-hmm.
So can you answer to that?
I can't really answer to that.
I think.
Anna, can you introduce yourself,
Sure,
please?
sorry, I'm Anna Antoniano, and I'm with the YWCA in Gabriel Valley. I work with Sophia Rodriguez here and Ms. Debra Ward, who's one of our speakers. That's one of the things that the LA County TV Council shelter directors is taking as an initiative, because we do hear that and we hear you. There's 19 shared 19 providers throughout LA County, and all of our intakes are different. We know that. Like for example, in ours, we take teenagers, we take men, it doesn't matter. But we're trying to standardize it so that it's a universal intake as opposed to just having. So we do hear that, and we, it's something in the works, and it will happen because we hear people saying that.
Okay, thank you.
So,
Because I was just wondering if this is still ongoing.
And also on the funding, like I know Dr. Nichols, you mentioned that there's usually no bed, and it just demonstrates the need for shelter beds. You know, over the last, I want to say maybe 8 years, I can only speak for the Y, but we lost funding to a lot of homeless dollars, and our shelter funding decreased a lot. And so it just shows you how the dollars for TV providers really is needed, and very, it's still prevalent.
And I know we have an online question, and we have 1 minute.
Yes, so I'm not gonna go over the comment, but the question is, how can we advocate for all medical providers to get training on trauma-informed practices and encourage more DVSA organizations to support survivors on with their sexual and reproductive well-being overall, not just during a crisis?
Can I answer that real quick?
Yeah.
ACEs are there. There's training. I'm not getting my question in. I just want you to know that. There has training for providers. Everyone can take that training, and it will educate you about adverse childhood experience, trauma-informed approach, and it will allow you to get certified so that when you do the ACEs and PEARLs, and it'll tell you how to do that, you can generate income for the healthcare provider. So that's the ACEs Aware. You just Google ACEs Aware and you look at provider training. Okay.
Thank you. And then I'm going to make a pitch to keep this conversation going. And if you really want to get involved, the Domestic Violence Council has a health committee where we talk about this every other month. So your comment about people working together, I think that is really the goal of the Leadership Council, but also the health committee, is to recognize that we have shared purpose, and that by working together rather than working against each other, we're actually able to help a lot more people. And I think the last thing I would say is, like, COVID-19 was a huge pandemic, and there's like the immediacy of COVID-19 right now, dealing with the actual physical health issues, but there is going to be a long-term impact, public health crisis for DV survivors and their kids who've been locked in their homes with perpetrators. So we really do need to come together as a community, as healthcare providers, service providers, legal providers, to really think about systems change and how we can have a greater impact in the community. So that's.
I was just wondering, could we hear the question from
The comment before?
Yes.
There
from the
was
online?
It was a comment before, and it was from Alejandra Guimaravedino, who asked the question. And her comment was, in my experience as an HIV health educator and program coordinator of a DVSA agency for the past 16 years, I have seen the negative health impact of domestic violence and sexual violence on survivors, especially on women and girls' sexual health. Providing survivors with sexual health literacy skills has helped tremendously, and I have seen how they feel comfortable approaching medical providers with questions, and also end shame about sexual health conversations in general. And that's when she asked about how can advocates
Come to the health committee.
And I think we're getting dollars where we're, I know for the YWCA, we just brought on Lily just here as our community engagement and our health education specialist. And we're trying to work through those type of dynamics with our older adult population as well as our domestic violence population.
Working for an agency that I'm really proud of, being a part of. I have made and established really good relationships with other agencies and other providers. And I learned that we're all like nonprofit organizations that were funded through federal grants and private donors, talking about funding is money, right? How much we have for this and how much money do we have for that? Requesting money and being my own investigator and asking those that I feel that I'm connected with of, aside from administration, we're one of many, many organizations, because we're nonprofit, that we're doing the work just as important as a doctor, as a registered nurse, as a EMR, as a police officer, because not even the law enforcement is trained to do what we do. They're not.
Yeah.
Mhm.
And because we have all this training and we're out there, where your county goes. We're one of all these nonprofit organizations that's underpaid.
Yeah.
And I'm amused, and when they say, oh yeah, this is how much this position is. And that's all an organization has. Many organizations.
Yeah.
And it's at the end of the day, it's really sad because I believe that everybody, like I said, here is because we're here because we love to do the work. Not because I want to do it just because I love what I do. And I work, many of us work beyond our expectations. And we're asked, well, you're not supposed to do that. How can we do it? Because if I don't do it, who's going to do it? Or because I want to help out. And I don't think of this is how much I'm getting paid, and I'm only getting paid for 8 hours a day.
Mhm.
But being funded as this is how much funds we have for these services. Let's gather together and fight for asking the government, federal, state, my workers need to get paid for the services that they provide.
No argument there.
Yeah.
Kathy. I think that's one of our long-term priority as well. I know it is in our, when I started, we were below, we were just minimum wage. We now are $2 above minimum wage. We're trying to look at every category of funding, and it is a group effort. And I just think, as Kate mentioned, the health committee being on DV council, those are vehicles where we can collectively devise strategies to advance that countywide.
And it's an advocacy issue for all of us because they can tell everyone to increase the salaries, but there has to be funding to do that.
Okay, so we went over time. I apologize for that. Can we get a quick round of applause for this fabulous panel and our audience in the room and online? Thank you, everyone. Please sign up to come to the health committee. Our next meeting's in November. The sign-up sheet's outside. Have a great rest of your day. And happy DV Awareness Month starting in 2 days. 3 days.
Thank you.
Yes, back in the main room.
Thanks, everyone.
Thank you, Dr. Nicholas.
Thank you.
You know.